Good morning, everyone. It's 8 o'clock, Thursday, February 14th. Thank you for joining our second week. And again, I'm Shannon Switkowski, the clinic coordinator. We will remind you to add your name, your institution, and this week we'd like to know your clinical role at your practice. If you could please add that to the group chat, that would give us a better idea of everyone's role for today. If you could please, throughout the meeting, keep yourself on mute. Unless you have a question, you can unmute yourself. We also have the chat feature to ask any questions if you would prefer to do it that way as well. We have a few callers who have joined via the phone. If you will unmute you right now, if you could please introduce yourself so that we can take your attendance. We have 513-379-9907.
Yes, that's Valerie Grant. Me.
Thank you, Valerie. Where are you from, please?
Cincinnati Health Network, Healthcare for the Homeless.
Thank you, Valerie. We have 937-836-2332.
Hi, I'm Mary Jo Trout. I'm a pharmacist with Wright State Physicians in Dayton, Ohio.
Thank you, Mary Jo. Were there any others?
Yeah, I thought there was one more.
419, there was a.
Yeah, there's one more somewhere.
419, let's see, we're looking down the list.
Maybe it's Compass Toledo.
Yeah, okay.
Maybe they.
They may have connected.
Okay, we don't see any others on the phone. Thank you. Okay, we'll introduce the ECHO team again. Again, I'm Shannon Switkowski. I'm the clinic coordinator.
I'm Goutham Rao. I'm the director of the ECHO program for Cardi-OH.
I'm Ann Nevar. I'm the program director for Cardio. Jessie Lewis, project manager.
Morning, Dee Littman. I'm on the organizing team for Project ECHO.
Morning, Siddharth Kalukian, data evaluation on Cardio.
Hi, I'm Rick Carnacci. I'm web content producer for the Cardio program.
Excellent. Okay, we have an overview of the hour.
Yes.
Selected.
To the next slide. So thanks for joining us. Happy Valentine's Day to everyone as well. So in terms of, are we doing a formal roll call? No, we're not. So I think if you haven't attended before, or if you're on the phone, please do introduce yourself at this point. So we're going to start with a didactic presentation. And to give you a brief overview of the purpose of ECHO is to uptrain clinicians across Ohio, so to improve their knowledge, their practices, their behaviors with respect to specific issues. And obviously, adult hypertension is our issue for this series. So ECHO fits into a broader scheme of trying to improve cardiovascular care, cardiovascular prevention and treatment for people across Ohio, especially Medicaid recipients, and that's what we're funded to do. And this is only one part of a much larger program, which we won't get into in too much detail today. So after the didactic presentation, Dr. Boland is going to present a single case. I think that's usually what we'll have time for. I don't think we'll be able to get to a second case. Usually when we have our first case discussion, people are a little shy. Don't want to speak up, although with this group I think we might get quite a bit of interaction. But if you are going to interact, if you are going to have any specific comments about the case study, I think it would be preferable if you did that on video conference rather than the chat feature, at least to start with. The chat feature is fine if we start to run out of time and you have some comments to make. I'm not going to try to avoid calling on any of the sites because there's so many out there right now, but we'll see we'll do the best that we can. The other thing I want to point out is the tag team presentation. Several of our presentations in the series will involve two presenters, this one included. So Dr. Shireen Khoury, who is remote, is going to be joining me. So we will pass the slides off to each other as we go through things over the next 20 minutes or so. So that's our overview, and I think we're just about ready to start. We're doing really well with time. Okay. So this particular presentation is called What's New in Measurement, and I can tell you the inspiration for this. So I'm not an adult hypertension expert. I am very heavily involved in the American Heart Association and was the chair of the obesity committee there. But almost all my research is in children and adolescents, and I study pediatric hypertension. I've been doing that since 2004. I can tell you that checking the blood pressure on a 4-year-old screaming kid in a practice is not an easy task. I've been doing it for 15 years unsuccessfully. So we're looking for alternatives to measurement in that context. Now, that having been said, the values you get in adults are not so great either. So Shireen and I have been looking into new measurement strategies that overcome some of those barriers that we'll discuss in a moment. So next slide, Rick. I don't have anything to disclose. And these are the remaining disclosures from the ECHO team, from Dr. Brzezinski, Karukian, and Bakris, who's not on this morning. Next slide. So what is the challenge of clinic-based measurement? Well, first of all, there's a huge challenge with respect to technique. And this goes back many years when, and I've done some of this in Chicago as well, observing nurses and medical assistants measuring blood pressure. It's been done in adults. And basic principles are often not followed. And I don't think it's a question of intent. It's just that the training has been very poor overall. So people sticking the bell of the stethoscope under the cuff, tucking it under there, which you're not supposed to do, using, not standardizing the arm that's used, not waiting a sufficient number of minutes. The most common problem, of course, is not using an appropriate sized cuff, etc. And so the goal, I think, in a busy clinical practice is let's just get some sort of measurement on these individuals. Now, why do we need to standardize measurements? So we're all measuring the same thing. If you use a different size cuff every single time, we'll never get a reliable blood pressure. Not that those methods, using the right arm, having the patient sit with 5 minutes of rest, 30 minutes without smoking, caffeine, etc. Not that those are magical things, but that means that we are following NHLBI guidelines and measuring basic things. So principles of office measurement include resting, seated with your back supported, arm outstretched, resting on the table, correct cuff and bladder placement, etc. From the pediatric world, we don't worry so much about the arm circumference in its relation to the bladder width, etc., which should be 40%. Most people don't have time to do all that. We just say if the cuff fits reasonably snugly around the arm, it's appropriate. It's an appropriate size. You repeat readings, and results should be written down. Do not encourage your staff to memorize readings as well. The other thing that's not mentioned here is you don't want the patient to be talking during their blood pressure measurement, which unfortunately takes place most of the time. It's a very boring thing, and naturally, I think people are more social, both on the clinician side and on the patient side as well. So technique is a problem. Inaccuracy, of course, goes along with technique as well. What are we measuring? If you have someone who's very upset, are we measuring something that's real or not? Insufficient data is one of the biggest problems. You need more than one blood pressure measurement. You need more than one during a single clinical encounter, and often we don't have those available to us. The other thing about clinic-based measurement is it does not correlate, and we'll talk about this a little bit later, it does not correlate that well compared to alternatives to cardiovascular outcomes, myocardial infarction, stroke, and other cardiovascular outcomes. So there's a huge challenge in how we measure in the clinical setting. So I'm going to turn things over to Shireen for a moment, who's going to provide us with some key definitions before we move on. Next slide. Oh, I'm sorry. Before we do that, I've got this slide that I want to mention here. This is brand new, and that's why I nearly forgot it. So as you can see, this study actually came out February 4th, so just a couple of weeks ago. And to me, it is providing fairly definitive evidence as to how we ought to measure in the clinical setting. And the comparison here is oscillometric readings, in other words, automated cuffs versus manual cuffs. I am a well-known critic of meta-analysis. Nevertheless, the conclusion here that automated blood pressure measurement ought to replace manual measurement, which I think it pretty much has in most clinical settings here in Ohio, is the bottom line for this. So it's okay to use the oscillometric measurement because the machine generally standardizes blood pressure measurement in the same way, whereas two individuals measuring blood pressure are going to do slightly different things, no matter how much training they have. So that's one thing. That's one aspect of office-based measurement we can talk about. So Shireen? Next slide.
Next slide, please. So good morning, everyone. I'm Shireen Khoury. I'm from the cardio team at Metro Health, and I'm in the Department of Internal Medicine. So a couple of definitions that kind of emphasize the divide between in-office measurements and at-home blood pressure measurements. So white coat hypertension, or the white coat effect that many people I'm sure have heard of, the idea is that when the blood pressure is consistently elevated in office, but the patient goes home or in an out-of-office setting and check their blood pressure and it's normal. And there's a little sort of back and forth in the literature about whether patients with white coat hypertension actually have an increased risk of adverse cardiovascular outcomes. Some studies have shown an association with increased risk of sustained hypertension, or like chronic hypertension, in patients with white coat hypertension, but it's less clearly established whether a patient with elevated in-office readings and normal at-home readings, or within normal range at-home readings, would actually be at risk of adverse cardiovascular outcomes. That's in contrast to the next definition. On the next slide, please. Thanks. So that's in contrast to masked hypertension, which is the reverse, where the blood pressure is elevated at home or in out-of-office readings, but they come to their appointments and actually the readings there are normal. And in the case of masked hypertension, there is a clearer correlation with among patients who have masked hypertension between that condition and developing sustained hypertension and developing chronic kidney disease and other adverse cardiovascular outcomes and death. So it's very common in patients to see masked hypertension in patients with chronic kidney disease. And as you can imagine, there's sort of a greater risk here of missing the diagnosis or missing the opportunity to manage that condition and treat the patient, because if the readings are consistently normal in the office, there may be no reason for the patient to have checked them at home. So sometimes I've seen in office this come up a couple of times where patients either had their family member had a blood pressure cuff and they happened to check their blood pressure and it was high, or they went to a pharmacy or something like that, and then they came to office and had normal readings. So I think one important thing to keep in mind when you see a patient with masked hypertension, however the manner in which it was discovered, is to compare the devices. If they're measuring with a home device, make sure that they're taking the blood pressure in an accurate way that Dr. Rao kind of alluded to on the first slide, and that we'll go into some more detail about, and that the devices are, validated in some sense against a machine that works properly.
Next slide. So now Shireen and I are going to talk about alternatives. So we've kind of laid out some of the shortcomings of clinic-based measurement. That's not to say that we are going to replace clinic-based measurement entirely with alternatives. In fact, in the first presentation last week, I pointed out to you that alternative forms of measurement, home blood pressure monitoring, for example, can be used to monitor treatment, titrate treatment, confirm the diagnosis, and from my standpoint, also remind the patient that they've got an issue that they need to monitor carefully. But it is not yet recommended that we use home blood pressure monitoring for actually making the diagnosis. So somebody comes in with a bunch of home readings, oh, you've got hypertension, let's put you on medication, let's put you on a low-salt diet. That's not appropriate yet. So what are some of those alternatives? First of all, there is what would be considered the gold standard, and that is 24-hour ambulatory blood pressure monitoring. This is a typical machine. And the technique is this is wrapped around the arm, and this is clipped onto the waist or around the chest. It doesn't really matter so much. And it takes blood pressure at regular intervals. Now, there are different protocols, but generally during the daytime, the interval is every 15 to 20 minutes and every 30 minutes at night. It is used to confirm the diagnosis. So you've got a number of clinic-based readings that are very high. You can use it for confirmation, for titration and monitoring less often. So there are some distinct advantages. First of all, it has a very strong correlation if we look at the mean values you get for systolic and diastolic blood pressure with cardiovascular events. It is perhaps the only way we can diagnose white coat hypertension, which Dr. Khoury just referred to. So the patient's blood pressure is high, repeatedly in the office, but they tell you, I don't think it's always high. I went to the pharmacy or went to to Giant Eagle, for example, and got my blood pressure checked, and it was normal there. This is a way to rule out white coat hypertension. Masked hypertension, maybe they went to an employment physical, maybe they used a friend's cuff, something else, and it was reported to be high. However, in the clinic, it is normal. And of course, monitoring response. It is a very cumbersome, at this point, I think, this is one of those areas to me that is ripe for frugal innovation. So there is a educational trust which validates, and you could click on this link, we're not going to do that now, but which validates devices that are approved for 24-hour ambulatory blood pressure monitoring. And there's only a handful of devices that have been approved. One major company is called Space Labs, for example. So for some reason, these devices cost between $1,700 and $2,200, even though there's nothing terribly special about them. It is difficult in the sense that how do I order 24-hour blood pressure monitoring? Here in Cleveland, my institution at University Hospitals, I wanted to order it on a patient, and people looked at me kind of strangely, because why do you want to order this? Well, why don't you call nephrology? And the nephrologist said, well, we've got one cuff. We don't usually hand it out to people. And of course, that's a legitimate concern. You may not see it again, for example. So those are some of the issues that need to be overcome with it. The other issue is that it needs to be interpreted accurately. So you cannot simply use our typical thresholds of 130/80 or 140/90 or 150/90 and say, oh, here's the 24-hour ambulatory blood pressure monitoring result. You will get different parameters. One that you will get is the mean systolic and mean diastolic value, and we'll talk about that in a moment. The other thing we use a lot in the pediatric world in terms of hypertension is something called load. It's the percentage of values that are above a certain threshold. So what percentage of the values are above 130/80? Or if it's systolic, what percentage are above 130? If it's 50%, we say the load is 50%. Let's move on to the next slide. So these are some proposed standards for home blood pressure monitoring, which Shireen and I will get into, and ambulatory blood pressure monitoring. So if you have a value of 120/80 in the clinic, that's the same with ABPM daytime. Blood pressure drops at night. That's called a dipping phenomenon. If it doesn't dip, you have a serious problem. And of course, 140/90 in the clinic is actually a daytime ABPM of 135/85 or 24-hour because of that dipping phenomenon as well. So there are standards. Now, these are completely arbitrary. They just estimated that this is what they ought to be. The precise correlation between clinic and nighttime ABPM is still yet to be worked out. Another disadvantage is when you inflate the cuff at night every 30 minutes, no matter how sound a sleeper you are, you have a tendency to start to wake up a little bit. And the thinking is that that also will raise your blood pressure to a significant degree. So there are some significant challenges there. Next slide. For that reason, and I just want to mention this to you because this is an area that I'm very, very interested in. As a pediatric hypertension researcher, I've given up actually on measuring blood pressure in clinic or with ABPM. And in Japan, the standard has become, both in adults and children, just over the last, I think since 2013, nighttime blood pressure monitoring. Still not very common here. You have your patient, they put their cuff on whenever they go to bed. You have 3 readings that are taken at 2, 3, and 4 a.m. And hopefully they're asleep at these times. And these are much less disruptive than measuring it at every 30 minutes. And this particular protocol is as prognostic in terms of cardiovascular events as a 24-hour ABPM. It can tell you some critical things. You will probably have a daytime blood pressure reading on these people. So if their nighttime blood pressure stays high, that's an extremely serious risk for cardiovascular events as well. So not yet ready for prime time, but ECHO is about what's new in measurement. I do anticipate that within the next 2 to 3 years, nighttime blood pressure monitoring will become much more common here in the United States. Next slide. I'm going to turn things back to Dr. Khoury.
Thanks. So like Dr. Rao mentioned, the gold standard is ABPM at this point, ambulatory blood pressure monitoring for making sort of actionable assessments. But as he also mentioned, that's pretty cumbersome, not super widely accessible, kind of a lack of awareness still. It's an emerging, an important emerging thing. But if people are going to be taking their blood pressures at home, there is some useful information to be gleaned from those readings. That's their everyday life and their normal setting. And the idea is that if they're taking them at home, that they're taking them accurately and consistently. And so some of these were mentioned earlier, but I actually have sort of a handout that I use in clinic with this sort of cartoon person sitting here just to sort of demonstrate and send patients home with a reminder of, what are the elements of taking a good, accurate blood pressure. So it's no caffeine or alcohol 30 minutes before, or smoking, notably 30 minutes before. Sit in a chair with your back supported and feet flat, not with legs crossed, not while fidgeting and whatnot. Having the correct cuff size, whether it's an obese patient and a consistent cuff size. Having the upper arm resting. Actually, in our own clinic setting, I noticed at one point that the patients were supporting their own arm, just essentially holding it up, and that was leading to a lot of variability. Having about 5 minutes of quiet rest, which, as you probably know, doesn't often happen in the clinic. People are just walking in from off the street, getting their intake questions and whatnot. So some clinics have a protocol whereby if the initial reading is elevated, it's repeated at the end of the appointment or after a few minutes of rest. Avoid talking, and ideally taking 2 readings separated by a couple of minutes. I like to have patients bring their device to the office and compare. It doesn't have to be every visit, of course, but to get a sense of whether, let them take their pressure and see if they have questions, if there's sort of kinks in the process there, and have some validated results as compared to office readings. And then of note, it's very important for them, if they're going to be going through this process and you're going to glean anything from that information, that they log the results. And I think it's more common than not to have folks say, well, my pressure's always around 140, but that's not as informative as sort of a day by day or even a week by week, however often they're taking it, what time of day was it taken, and what are the results. So in terms of logging, many people just keep a paper log, but there's also a few digital apps available now wherein you can either manually enter those results, or we have another slide later about this, but whatever the method, to make sure those results are logged with a date and time and can be reviewed to get any useful data. And then of note, I've had folks ask about, and I think these are sort of out there, some wrist monitors, like wrist cuffs that you can use, and also some finger cuffs that are coming out now, but those have been less reliable, especially in the sense of like maintaining position, getting the wrist to the level of the heart. Wouldn't really recommend over just like a traditional cuff. And then measuring in different arms and noting which arm was used for the measurement. Small differences, usually not a big deal, 10 or 12 millimeters of mercury. If people have AFib, sometimes that can be a reason for differences, but above 10 or 12 millimeters of mercury, consistently different between the arms, could be a sign of peripheral artery disease in the upper extremities. That should be investigated. I would say if you're at 15, 20 millimeters of mercury difference, definitely something to take note of.
Next slide.
And so mentioned that, there's different devices emerging, and while the wrist and finger cuffs aren't very well validated and aren't as reliable, there are some devices built on the foundation of a traditional cuff, but trying to make logging those results and use of the data more efficient and more consistent. So one of those is this Apple Care Kit. Full disclosure, no stock in that company, no particular affinity for this product, but the idea is that this is one that is basically a cuff that imports the readings via, it's like a Bluetooth blood pressure cuff basically, that imports the readings into a digital app, and that those can be stored, shared with a physician, and they can be integrated into other programs. So actually there are some research studies looking to validate and to integrate some of this data. One of those is the MyCore study. It's like a post-MI hospital discharge study, but there are also some concerns in 2 groups with these new and emerging digital devices. One of those is, again, reliability. They're less studied, less tested, and so it would be important to validate, the readings themselves. Another interesting sort of emerging question is that these products are, commercially available. You can go online and pick up, these things. And then there's actually some papers published recently on online reviews, the online reviews of users, and how do those impact uptake of the devices and impression of validity and reliability of those devices in the community and even among physicians. So just to kind of use, some caution in these new devices that are less studied. But I do think there's an opportunity here in terms of, helping patients manage their data and helping physicians kind of partner with patients to work on a shared set of information. So, something to keep an eye on.
Next slide. And Shireen,
So,
yeah, go ahead.
Yeah, sure. So to kind of sum up what we spoke about and then, go through the case and questions, there are certainly challenges to accurate and efficient home and in-office measurement. So we know that the gold standard is ABPM if that's feasible. And for our part, I think a good first step and initial sort of building blocks are to educate ourselves and educate patients on accurate ways to take home blood pressure measurement, log those results, and to try and align the patient and their presentation with what's the most feasible and effective method to track their blood pressure and give an accurate assessment and direct them to the right type of care.
Okay, thank you, Shireen. And we're going to just pause for a moment, see if there are any specific questions about that didactic content. Between the two of us, we'll have a half intelligent answer to.
I had a question about, and maybe this is just a practical thing, but it looked like the new HEDIS guideline, and I don't think they've put it out yet, was talking about using wireless upload of home blood pressures and allowing that as opposed to an office blood pressure for quality. And I have not yet tried to integrate sort of wireless home blood pressure monitoring into our EHR system. I don't know if others are doing that in any way and how they've made that work. So I just throw that out there.
Okay, thank you, Sherry. So interestingly, your friend and mine, David Kalber, is really doing that right now at Metro Health, and he's very keen on it. The integration with EHR, I don't think that's too challenging. Epic has had that for some time. They've had it for the Withings Wi-Fi scales for patients with heart failure, for example, who are asked to weigh themselves every day. If they don't, they get a call from a nurse or whatever, just to make sure they're not getting into trouble. So I don't think that's too difficult. The devices, I think David or someone else was telling me, they're not, see, the home blood pressure monitors are between $100 and $150, reliable ones. And that's why 2/3 of all adults with hypertension over a certain age of 60, they have a home blood pressure monitor, and you can get them covered by insurance sometimes. The Bluetooth or the wireless ones are more like $400 or $500 from my understanding. So they're not inexpensive. And that's been somewhat of a barrier to it as well. But I think that's definitely the future, and it's definitely coming. And we're lucky we have somebody who's here in Cleveland, here in Ohio, who's very passionate about it as well.
Yeah, I mean, I think that the cost is variable of some of the Bluetooth products, and my big concern with that is that would it be sacrificing reliability for the sake of convenience and ease? And there's value in both of those. Certainly value in patients having their blood pressure monitored more frequently and more consistently, but I'm actually pretty interested to see what some of the initial studies show in terms of are patients more adherent as a result of having that data, or like what do we see? Because from what I've seen, it seems premature to call that a marker of quality, to say that Bluetooth readings or like digital home readings are as good or better than traditional readings. I don't know that I would be ready to say that.
We have sent out the post-clinic survey in your emails. Please go ahead and fill that out as soon as possible. We will keep it open through Friday at 5 p.m. In case you have to run out to clinic right now. We also sent out a last call to complete the needs assessment and the statement of collaboration forms. Those will be coming down shortly. And reminding you that next week's Echo Clinic is February 21st. We have Unrecognized Hypertension and Strategies to Improve Diagnosis with Dr. Rao and Roselle and Roche. So thank you for joining, and we'll see you next week.
Thanks,
Happy
everyone.
Valentine's Day.
Have a great day. Thank you.
Bye.